So thank you so much for the opportunity to be here, and thank you. I also want to echo my thanks to Katrina for sharing your story. And I actually make my comments from the vantage point of an addiction medicine physician treating people with opiate use disorder in an urban outpatient specialty setting in Baltimore City every day. And we see people who have lost loved ones who that drives them into treatment. We see family members who really are at their wit's end, and we see people who are coming into care for the first time ever in their 60s because they are terrified. And they're terrified of dying because there are people who are dying all around them. And so I absolutely share your passion that we need to do better. And I also get to see the hope and the recovery. And I think that's the other piece of this, is that we do have medications that work, and you've heard some of the evidence of that. I also am speaking to you, having worked in a hospital system, as a consultant to the Maryland Behavioral Health Administration, and also as the secretary for the American Society of Addiction Medicine. And so in thinking about kind of the few minutes that I have, I wanted to really discuss two specific areas. So one is reimbursement challenges, and then the other is administrative burdens that are really related to the lack of adequate technology for specialty addiction treatment. And in terms of the reimbursement challenges, I mean, I think, Richard did a great job of really walking through some of the many reimbursement issues related to the underutilization of medications, insufficient payments for office visits to really support the time that it takes to thoroughly diagnose, develop, and secure patient agreement on a treatment plan, because we really need that active patient participation. Limited insurance coverage of non-face-to-face and non-medical services that patients need to succeed in treatment and recovery. Limited payment structures that are available to enable proper care coordination. Burdensome utilization management techniques that make it difficult to deliver timely, effective treatment, as we've heard. And I'm going to add that limited payment for that patient outreach and engagement perspective, because that is, and services, that is really incredibly important. I also wanted to mention that to deal with these issues, ASAM and the AMA have jointly cooperated on the development of an alternative payment model, as Richard mentioned, for outpatient OUD treatment outside of OTPs, called the Patient-Centered Opioid Addiction Treatment, or PCOT model. And that model has four aims: reimburse appropriately, coordinate care, control costs, and pay for quality evidence-based services. And reimbursing appropriately, essentially the model mentions two pieces to that. So one is this one-time initial payment to support the initial evaluation, diagnosis, treatment planning, and an initial month of outpatient treatment that includes medications, either buprenorphine or naltrexone. And then an ongoing monthly payment to support the provision of that ongoing medical, psychological, and coordination of social support services. Being able to actually coordinate care so that providers in this model would be expected to coordinate the delivery of all of those medical, psychological, and social support services through two different care delivery options. So one would be a fully integrated care model all under one roof, where one provider provides all those different services. But the second would be a coordinated care delivery model that really uses very deliberate collaborative care arrangements, formal collaborative care arrangements for providers who can't provide all those services under one roof, and accommodating and incentivizing providers to use technology support tools in order to be able to actually do all that care coordination. Controlling costs, so meeting patients at the right level of care where they are. So to reduce or eliminate unnecessary spending on ineffective treatments, inpatient residential treatment that the patients aren't ready for or willing to participate in, reducing avoidable ER visits and hospitalizations, and doing that through the use of standardized evidence-based assessment tools such as the ASIN continuum that comprehensively account for patients' needs across medical, psychological, and social support domains. And then holding people accountable for that care so that physicians enrolled in this model have to attest that they are meeting certain quality standards to bill for the PICO payments, and that they will assume both upside and downside risk based on performance according to treatment initiation and utilization measures. And as Richard mentioned, there are many other models out there, but this is certainly one and an example of one that should be tested. So the second area I wanted to just mention and talk a little bit about are those administrative burdens related to the lack of adequate technology for specialty addiction treatment. Because to know if we're making a difference in the lives of people, both on a population and an individual level, we need data. And to get meaningful data, we need to look beyond claims and short-term episode of care measures. And I'm going to give you an example. So in Maryland, the state has been convening an OTP quality of care work group that actually developed a dashboard with basic metrics, such as the percentage of patients with at least 3 consecutive opiate and other negative drug tests. But we can't actually get that data because it exists at the provider level only, and many of those providers have systems, electronic medical record systems or paper record systems, and their electronic medical record systems are not interoperable with anything else. And double and triple data entry is the norm. Currently, behavioral health technology really lags years behind the rest of healthcare. And according to the National Health Records Survey, 90% of primary care offices have adopted electronic health records, and that statistic is only 60% for behavioral health systems. And part of that lag, there are many reasons for the lag, and we can talk about that. But even with appropriate consents in place, the availability of systems that are capable of efficiently capturing and reporting on basic healthcare data, like liver function tests, is very limited. And the costs associated with their adoption when they are available are significant, especially for nonprofit community care providers. And what drove innovation in electronic record systems for general health care was a concerted focus, clear metrics, and funding. And the time really has come for the same effort for specialty behavioral health. So thank you.